Good morning, everyone. I think I've probably met most of you, but for those whom I haven't met, my name is Elena EFryeNaharro. I'm one of the co-residents, one of the chief residents, one of the fourth years, and I will be sticking around at the University of Minnesota next year for my heme path fellowship. So in the spirit of learning as much as I can for next year, I thought it'd be a prudent time to learn more about the two new heme classification systems in heme path, and we will be kind of paring down the topic to just mature B-cell lymphomas today because there's just too many changes overall. So, all right. So I do have a few goals for us today. I hope the people who are attending can do three things after this talk. First, be able to kind of discuss why and how the ICC, or the International Consensus Classification, was formed. Be able to list the new entities within the two new classification systems. And then finally, to be able to identify and assess the differences between the old system and the two new systems. So along the way, I will be using case examples to break the lymphomas up into categories and to showcase the new changes and the new entities. So starting off, I'm sure anyone who's rotated through heme in the recent years knows that the diagnostic criteria that heme paths use comes from the WHO classification, and that the more recent version, the fourth revised edition, is what is typically used. But after many advancements in things like targeted therapies, and as we know more about the molecular biology of some of these cancers, many felt that updates were necessary to some of these entities in the 4R. And while updates are certainly appreciated and encouraged, unfortunately, that has led us to a dichotomy of classification systems. So now, instead of the unified system, we are transitioning towards the WHO-5, which is led by the International Agency for Research on Cancer, the IARC, that has kind of helmed most of these fascicles for a while, and then the International Consensus Classification. So before we learn about all these new entities and all the changes to existing entities, I wanted to take a look back at the history of heme classifications and kind of figure out how we ended up here. All right. So starting off with the Blue Book series, the first edition, these really started in like 1967 to 1981. Heme was notably absent. And kind of in the pre-90s world, the classification of lymphomas, leukemias, myeloid disorders was mostly done by like single expert classifications, and then really started to be classified by things like the AFIP fascicles, the French American British Cooperative Group, Polycythemia Vera Working Group, but none of these actually represented an international consensus or incorporated knowledge from other divisions that weren't pathology, like oncology, epidemiologists, things like that. But in 1994, the International Lymphoma Study Group was established, and here international experts proposed what's called the REAL classification, which stands for the Revised European American Lymphoma Classification. Here they defined, the clinical information for each entity, the morphology, corresponding immunophenotype, and eventually the REAL co-editor, Dr. Sobin, approached Elena Jaffe, who's well known in the heme world, to develop a similar classification for the Blue Book series using that same REAL classification framework. So in 2001, heme was finally introduced into the WHO Blue Book series under the third edition, and it was really kind of overseen by two societies, the Society for Heme Path here in the States, and then the European Society for Heme Path, or European Association. And that led to the WHO 4 and the WHO 4th Revised Edition that came out in 2008 and 2017. And after that 4R edition came out, after several exchanges between the IARC series editor and leaders from the Society for Heme and the European Association of Heme, the heme societies felt that time for updates was necessary given the major progress in molecular and genomic studies. But unfortunately, no consensus was reached by their kind of deadline of February 2020. So while they didn't have the official go-ahead to convene to start the fifth WHO, they did anyways establish the International Consensus Classification Committee in September of 2021. And kind of at the same time, after 2018, the fifth WHO series started to be in the beginning stages for all tumor volumes. But in late 2021, really, that's when HemePaths and other knowledgeable people in the heme world were invited to start conceptualizing the new volume. And then this all led to a couple developments last year. So in June of 2022, the WHO did release a lymphoid review and as an article in Nature, whereas the ICC had published a more definitive format than the WHO, their own lymphoid review in Blood. So that led to, here's kind of the author list for the fifth edition of the WHO. And altogether, there were 420 contributors, including Dr. Siebert, who was on the 4R edition. But really here they focused on fundamental structural and content updates that reflected the scientific developments that had occurred in recent years and clinical advancements with kind of three pillars in mind. So their goals were to improve the clarity and practicality of disease categories, to make it applicable for the entire world, knowing that small community hospitals or other regions across the globe may not have access to the most advanced molecular and genetic assays, and then obviously clinical pertinence as well. They took a pretty conservative approach in to making changes in the nomenclature. Overall, kind of the framework of the WHO5 is the same as the 4R, with the same hierarchy as they lay out their chapters, but they did remove provisional entities that were in the WHO 4R because they felt that they lacked sufficient evidence. Additionally, they did include things that weren't in the 4R, like germline predisposition syndromes associated with lymphoid neoplasms, but that's a little bit outside the scope of today's talk, so we won't be including those. And then they worked pretty hard to refine the criteria and provide kind of two tiers of criteria. So the essential criteria, which they meant is to have like the must-have features, the minimal criteria allowed to make a diagnosis, and then the desirable criteria, so the nice-to-have features that support a diagnosis but are not actually mandatory. So regarding the WHO5, the review for the lymphoid and the myeloid is out now, and I believe the physical textbook is coming any day now. But for now, we do have this online beta version. I'm sure a lot of people that are attending today are familiar with the Blue Book online version. It is really nice. It is searchable. But seems like it's kind of a primer for what's to come. And just to see the scope of all the mature B-cell lymphomas, obviously this list is very, very long, and we will not have time to cover everything on here. So I've tried my best to pick out things that had significant changes, things that had changes both in ICC and especially new entities as well. So regarding the ICC, you'll notice prevalent names like Dr. Campo, Dr. Jaffe, Dr. Swerdlow, and these are all names that were on the people who contributed to the fourth revised edition. And altogether, there were 138 authors, and they truly feel that this is like the direct descendant of the fourth revised edition because it's a lot of the same minds that help write it. But overall, their goals are pretty similar to the WHO5. They wanted to provide clarification for some of the provisional diagnoses from the fourth revised, to refine nomenclature to the current knowledge of biology and add new entities, to incorporate updated molecular findings for things like targetable mutations. And finally, which I think this is the goal everybody has in mind in medicine, to overall improve patient outcomes and quality of life. So now that we've talked about the background and how we got here, I think now it's time to talk about the changes in mature B-cell neoplasms. So starting off with the first case, and these are all cases that were encountered here at the university. This is an 85-year-old woman who presented to emergency department with symptoms of sepsis. She did have like urine cultures that are positive for E. coli, so urosepsis. But she had a prominent history of persistent normocytic anemia, and the CBC reflects that. And overall, the white blood cell count was elevated, but seems to be mostly composed of neutrophils. So overall, she ended up getting 2 peripheral smears performed that again showed the neutrophilia and the normocytic normochromic anemia. But interestingly, every time they tried to do peripheral smear on her, she had this platelet clumping. Those felt to be really artifactual. And a comment was eventually made that while the platelet clumping is likely artifactual, in vivo clumping can occur with things like myeloproliferative disorders, weird presentations of LGL leukemia. So she eventually did get flow done. Flow was performed on the peripheral blood. Let's see if I have a pointer here. So she had a very small B-cell clone here that had dim CD5, expressed 19 and 20, had kappa restriction, and was seen to be small by like forward scatter. Here it is negative for CD23 and CD79B. Overall, this really just constituted like 0.2% of all events. So if you look at the white blood cell count, multiply it by the percent of the events, it's under 0.5, which is a magic number that we'll discuss in a couple seconds here. So overall, as far as the WHO4R, I guess this is best diagnosed as a non-CLL type MBL. I'll admit that the history is a bit of a red herring with the thrombocyte, the weird platelets and such, but overall, we'll see how this changed in the 2 new classification systems. So the WHO4R, in regards to MBL, really comes in 3 flavors. They talk about the CLL type, which must have co-expression of CD5 and CD23, usually with dim CD20, and it's further classified into this low count that's under 0.5 and a high count that's greater than or equal to 0.5. Then there's the atypical CLL type that can have the atypical CLL type MBL that can have CD5 expression with a bright CD20, and CD23 can be positive or negative. And then there's a non-CLL type that is characterized by CD5 negativity or dim CD5, like in this case. So in comparison, the WHO5, it's similar. They do have 3 new subtypes, the first of which they call a low count or clonal B-cell expansion. I don't see anything so far about the need for CD5 positivity here, but they have that same cutoff of below 0.5 as the low count in the 4R. Secondly, they have the CLL SLL type, which more than likely requires a CD5, but here the counts are greater, so greater than or equal to 0.5, with a caveat that the total B-cell count must be below 5. And then non-CLL SLL type is the third type, and this is thought to represent mostly like marginal zone origins, things that are like 5 and 10 negative. They do not mention right now anything about atypical CLL type. We'll see if that changes when the textbook comes out. As far as the ICC, the categories are the same as the 4R, but they do want to give credence to the tissue-based MBL and recognize it as an entity as long as cases don't show things like proliferation centers. There's no adenopathy that's bigger than, I think, 1.5 centimeters, and that the peripheral blood is not diagnostic of CLL, SLL. Oh, and if you'll notice for the duration of this talk, anything listed in yellow is related to the 4R edition, green is the 5th edition, blue is the ICC, and then finally things in purple are things that are shared between the two new classification systems. So regarding CLL, SLL, there aren't really diagnostic criteria changes. Really, there's just an agreement between both systems on the flow panel that should be used to kind of work up CLL, SLL. And they also stress the importance of knowing the mutational status of a few things for prognostication and for targeted therapies. Things like immunoglobulin heavy chain and TP53. And both systems do recommend using Richter's transformation instead of syndrome. But the ICC especially warns that people should be very careful not to overcall Richter's and to make sure that patients hadn't recently stopped a drug called ibrutinib, especially as these Richter's transformation-like changes are reversible when ibrutinib is resumed. But the WHO has introduced a term called pro-lymphocytic progression of CLL and has entirely removed the entity BPLL, owing to its heterogeneous nature. And honestly, a lot of these cases that had fit the BPLL have been moved into a new entity that we will talk about shortly. In comparison, the ICC still regards BCPLL as an entity as long as there's no previous history of CLL to exclude CLL progressing to BPLL. That cases are negative for cyclin D and SOX11 to exclude mantle cell, and that cases lack hairy surface projections, obviously to exclude hairy cell leukemia. Regarding another CD5 positive small B-cell lymphoma, both new systems stress the importance of recognizing other cytogenetic abnormalities when it comes to mantle cell lymphoma. Many of you know that the IGH-CCND1 fusion that results from 11-14 translocation that relates to a cyclin D1 overexpression is the hallmark of mantle cell lymphoma, and it's present in about 95% of cases. The definition has been revised a bit to include cases that lack the CCND1 rearrangement. So these findings were already present in the 4R, but cryptic rearrangements of Ig kappa or lambda enhancers acting CCND1 is something that both new systems address, that is a possibility. And then cyclin D1 expression, if it is negative, both systems agree that this could be due to CCND2 or CCND3 rearrangements. And additionally, the WHO 5 talks about CCNE rearrangements. Overall, the WHO 5 also emphasizes the need for risk stratification and how it's been improved, and the need to identify high-risk subgroups like blastic and pleomorphic mantle cell lymphoma, cases with TP53 mutations for particular things for therapy, as TP53 mutated cases are usually resistant to things like tyrosine kinase inhibitors and CAR T therapy. And, let me go ahead. And both the WHO 5 and the ICC warn that some aggressive B-cell lymphomas have just naturally secondary CCND1 rearrangements. So just because you see that rearrangement, do not call this blastic or pleomorphic mantle cell lymphoma in aggressive cases. Great. So moving on to case 2, this is a 67-year-old woman who presented to dermatology clinic with a pink papule on her left arm. And our derm colleagues saw this case and were told to rule out atypia. So here we have a skin shape biopsy, and here it seems like it's a dense bottom heavy skin specimen. It has multiple nodules here of probably lymphocytes, owing to the theme of this talk, and it seemed to be going into the superficial subcutaneous fat. And on higher power, see. Might have to get rid of version here. Maybe we'll have higher power. Maybe not. Well, anyways, on higher power, these cells are small to intermediate in size. Maybe this will work now. Nope. Okay. Well, they're small to intermediate size, and the periphery of these nodules have plasma cells, and the infiltrate overall is positive for CD20. BCL6 seems to be kind of preserved in maybe a germinal center here, maybe picking up some T cells in background. CD21 is mostly negative here. Maybe there's like a faint blush here at the germinal center. But otherwise, there seems to be, if my slides will pull up, kappa restriction here. And maybe if I end this pointer, I think that's my problem here. Okay. So this case was ultimately signed out as cutaneous marginal zone lymphoma by our derm pass, which is classified under extranodal marginal zone lymphoma in the 4R edition. I apologize for what's going on with my slides. I'm not quite sure why. Okay. But as you can see here in the 5th edition and the ICC, the naming has changed to make it its own entity. So the WHO4R includes cutaneous marginal zone lymphoma as a subtype of extranodal MALT. Both new classification systems have made the cutaneous variant their own entity because of different clinical pathologic features, cytogenetic features. You'll notice here that while primary cutaneous resembles like nodal, extranodal marginal lymphoma, in immunophenotype and morphology, it does not have the rearrangements that are found in like things like ocular MALT or the mutations, and the pulmonary gastric MALT have a different fusion as well. So really the cutaneous marginal zone lymphoma is known for having like fast mutations, but nothing super prevalent in comparison. So the WHO calls it a lymphoma, while the ICC prefers to call it a lymphoproliferative disorder because of its slow-growing nature, low propensity for it to disseminate, and the good survival overall with conservative treatment. Both new classification systems do recognize 2 subtypes, however, based on the cells that express like immunoglobulins. So IgG is the most common of all, included in the heavy chain class switch. It makes up 75% of those cases, and IgG4 actually makes up like 50% of those. Otherwise, IgM in the non-class switch is about 10%. All right, and then pediatric nodal marginal zone lymphoma has also been upgraded to its own entity in the WHO5. While it is strictly a provisional subtype in the ICC as it was before. It does have overlapping features with pediatric type follicular lymphoma, but as there isn't a lot of sufficient evidence to group these entities together, it has not been done yet. While splenic marginal zone lymphoma hasn't changed in the new editions, the other splenic entities have. And so these are the first one here is a new diagnosis altogether. So this is called Splenic B-cell lymphoma leukemia with prominent nucleoli. A lot of the heme names are very long. But this entity actually includes the hairy cell variant that was discussed in the 4R and was here a provisional entity under splenic B-cell lymphoma unclassifiable. But SBLPN also includes BPLL. Remember how I said that those cases have moved? And altogether, SBLPN affects the elderly. It's known to be more aggressive than hairy cell leukemia, the classic type. It is notably negative for those classic hairy cell markers, C25 and XNA1, TRAP. But the ICC still calls hairy cell variant as a true thing. So whatever you call it, I think it's an important distinction to make from classic hairy cell. as it does not have the BRAF mutation and is also resistant to the therapies that they use for classic clearing cell. Additionally, there is another entity, the splenic diffuse red pulp small B-cell lymphoma. This was a provisional entity in the WHO4R listed under those splenic unclassifiable, but it has been upgraded to its own distinct entity in the WHO5, while it is still provisional in the ICC. And the reason the WHO5 had upgraded it is they thought it had pretty significant different findings from SBLPN and splenic marginal zone, with things like prominent intrasinusoidal growth pattern, and high frequency of like B-core mutations. But the WHO5 does recognize that this is a really hard entity to kind of discriminate from those other ones. So they similarly advised, just as the WHO4R had, to use the CD200 and CD180, or the overall ratio, to help isolate that out. All right, and then the last one of this category, lymphoplastic lymphoma. The WHO5 does agree with the 4R that in terms of a cutoff for involvement in the bone marrow, you have to have above 10% of these clonal lymphoplastic aggregates. But additionally, the WHO5 does add 2 subgroups based on the IgM. And so the first here is LPL, IgM LPL Waldenström's. It makes up about 95% of cases. It has the characteristic MYD88 mutations in most of its cases, but some don't have that characteristic mutation. Just because you don't have that mutation doesn't mean that this isn't LPL, because some cases do harbor mutations like CXCR4 that are downstream of that. The second variety is the non-Waldenström's type. It makes up 5% of cases. And here, this also comes in a few flavors. It can still have IgM, but here it has cases without bone marrow involvement. There's also the non-secretory type and the IgA, IgG type. The ICC is a little bit different when it comes to the cutoff for LPL. They recommend following the guidelines back from 2003 from the International Workshop on Waldenström's. And here they say that even if it is less than 10%, as long as you have clonal evidence by flow or IHC that these are clonal lymphoplasmacytes, that's probably good enough. So additionally, both new systems do recommend looking for that MYD88 and CXCR4 screening, especially because CXCR4 does have some other information associated with it, such as hyperviscosity, and then I think the CXCR4 mutation LPLs can have some resistance to things like ibrutinib. So moving on to case 3. This was a 61-year-old woman who presented for long-standing pelvic pain. She ultimately got an abdominal CT that did show a right inguinal lymph node that was enlarged. She did have it biopsied at an outside institution, so we don't have the slides for that. But this was overall called a suspicious for B-cell lymphoma biopsy. So she proceeded with an excisional biopsy of this inguinal lymph node. And here you can see some architectural effacement by lymphoid process. You can see there are back-to-back follicles of different sizes. The mantle zones have been attenuated. If my magnifying glass works, yep, you can see that it's percolating into the capsular fat. And then on high power here, there are increased centroblasts. These are true centroblasts here of more than 15. Be careful not to call follicular dendritic cells as centroblasts. So centroblasts should have much bigger nuclei that are ovoid and have 1 to 3 prominent nuclei. But you can also see that the mitotic figures are readily absent here in the background. This entity was positive for PAX5, similarly CD10 and BCL6. And BCL2 picks up some of the neoplastic cells in the germinal centers, but also the T cells in the background here. My slides are thinking. Okay. CD21, additionally, it shows the follicular dendritic meshworks. Some of them are a bit maybe expanded, some are disrupted on the edge. MUM1 is negative, which would be important in a second. And KS67, the proliferative index is increased in the follicles at about 60%. The fish studies that were done showed no significant rearrangements or fusions. So under the WHO 4R, this is best classified as a grade 3A follicular lymphoma. And we'll see how these things kind of changed a bit in the WHO 5, not so much the ICC. So here, as you can see, follicular lymphoma and the 4R has the 1, 2, 3A, and 3B grades. Under the 5, they made grading really only pertinent to classical follicular lymphoma. And ultimately, it's no longer grading. They recommend more of a biologic grade here. The decision was made after extensive discussions about how poor the reproducibility of grading was because of things like limited biopsies, poor identification of real centroblasts, and ultimately because grades 1, 2, and 3A are fairly similar in terms of clinical outcomes. However, the ICC did retain grading because they felt that the difference between 3A and 3B is obviously critical because of different treatment plans. Those cases of 3B are actually treated as DLBCL. So they've kept the grading as mandatory. The classic type of follicular lymphoma is about like 85% of all cases, but the WHO now calls a follicular large B-cell lymphoma as those with areas of DLBCL. It's kind of equivalent to like the grade 3B. And you'll see here in terms of the ICC, the grading is the same, but they do give additional guidance in making that call for 3B versus 3A because, you know, sometimes cases have really challenging morphology. So here they say that if there is a BCL2 rearrangement or if there's CD10 positivity and you see things like MUM1 is negative, and the bone marrow is frequently involved, and that seems to lean more towards a 3A, whereas 3B has the inverse of that with positive MUM1. They do recommend additionally to get IRF for fish testing, so they don't actually call a large B-cell lymphoma with IRF for rearrangement in its place. All right. And then additionally, the WHO 5 has 2 more subclasses. This has actually changed a little bit from the review that they released in June. So in June, they called follicular lymphoma with uncommon features, and had this follicular lymphoma with predominantly diffuse growth pattern kind of under this umbrella. Now, this growth pattern is basically like synonymous to what the ICC is calling it as the BCL2 rearrangement negative CD23 positive follicular sentinel lymphoma. Both of these have STAT6 mutations, 1p36 deletions, and commonly are CD23 positive, as the name suggests. But under the WHO 5 in the lymphoid review that was released in June, these were lumped, but now they seem to be separated out in the Blue Book online. And this has actually been called now unusual cytologic features instead of uncommon features. So a little change, but overall, there's one more entity that is discussed actually in the ICC. So the ICC has taken the testicular follicular lymphoma variant from the 4R and made it its own distinct entity. It's not even mentioned in the WHO 5, so we'll see if that also changes in the textbook edition, if they'll mention it. But we had quickly discussed a large B-cell lymphoma with IRF4 rearrangements. Here in the WHO 5, it's actually listed under aggressive lymphomas, whereas in the ICC, it's positioned under follicular lymphomas. But both the classifications have made it its own distinct entity. This diagnosis is prevalent mostly in kids and young adults. It's pretty localized, has an excellent outcome, has that partially follicular growth pattern, but adult cases seem to have more genomic complexity, have that activated B-cell like gene expression profile, And ultimately, cases are based on, diagnoses are based on the IRF4 rearrangement by FISH. That being said, if you don't see that, if you do see mutational evidence of IGH or IG kappa lambda breaks, that may suggest a cryptic rearrangement, which also qualifies. Additionally, the ICC wants to warn people to not include aggressive B-cell lymphomas that have, other additional rearrangements associated with BCL2 or MYC in this category. All right, and then case 4, this is a 52-year-old woman who had a history of high-risk DLBCL. She had prior relapses and now had been about 50 days after CAR T cell therapy and rituximab. She did have a prior bone marrow biopsy that had shown low-level involvement by a CD10 positive B-cell lymphoma that was favored to be like a follicular lymphoma. But right now, she presents for 3 right axillary masses that are new. She comes in and she does get a punch biopsy. So we seem to have a lot of like skin cases today. But here you can see the punch biopsy shows obviously architectural effacement. There's a diffuse infiltrate of lymphocytes at the bottom of this biopsy into the subcutaneous fat. And on higher power, the cells are, if they pull up here, nope, are intermediate to large in size. Here, CD20 is negative, likely from her rituximab. PAX5 is positive, as is CD10. BCL6 is weakly positive. A little hard to appreciate, but it's there. And then c-MYC shows overexpression in 80 to 90% of the nuclei. BCL2 is negative, so it's not overexpressed in this case. It's just highlighting background T cells. Follicular dendritic meshworks with CD21 are notably absent. The Ki67 is very high, at 90% or above. And then FISH was notably significant for both rearrangements in MYC and rearrangements in BCL2. So I'm sure people probably can see where this is going. So this by the 4R was called high-grade B-cell lymphoma with MYC and BCL2 and or BCL6 rearrangements. That is what it was called in that edition. So this has undergone some modifications in naming. So here, the WHO5 and the ICC have reframed and reassigned this entity. As cases with dual MYC and BCL2 rearrangements show a gene expression profile similar to follicular lymphoma and dermal type DLBCL, and they are genetically homogeneous. Both classifications decided to make this a distinct entity, the ones that just have the MYC and the BCL2 rearrangements. This is a comparison with the cases that have MYC and BCL6 rearrangements, but not BCL2. These are noted to be more heterogeneous, and correspondingly, the ICC has made it a provisional entity, owing to the fact that even though it's maybe not as genetically defined, these cases still have a really poor prognosis and aggressive nature, just like the BCL2 and MYC dual partners. In comparison, though, the WHO5 has not made it its own entity. They say in cases with MYC and BCL6 rearrangements only to really analyze morphology and then to just classify it as a DLBCL NOS or a high-grade B-cell lymphoma NOS. Another high-grade B-cell lymphoma was this entity that the WHO4R had called Burkitt-like lymphoma back when, with 11q aberration. And they said they called it like Burkitt-like lymphoma because of its morphology. It had that characteristic starry sky appearance and an immunoprofile with CD10 positivity and BCL6 positivity commonly BCL2 negativity, and had the same high proliferative index that Burkitt is known for. It's also seen more frequently in kids and adolescents like Burkitt, but there are some stark differences between this entity and Burkitt lymphoma. The genetics are quite different, and here, high-grade B-cell lymphoma with 11q aberration is known for having obviously those 11q changes with gains and loss patterns, some telomere loss as well, 11q to 4, and it doesn't have the hallmark MYC rearrangements like Burkitt. It also doesn't have the SWI, SNF complexes and mutations in ID3 and TCF3, things like that. But as far as where the WHO5 and the ICC classify this, so WHO5 calls it high-grade B-cell lymphoma based on the morphology, as these cells typically have that blastoid morphology. The ICC prefers to call it a large B-cell lymphoma instead of high-grade based on molecular studies that suggest the mutational profile is similar to DLBCL, the germinal center type. They have mutations like GNA13 that are in DLBCL, and they kept it as a strictly provisional entity as they are not sure if the 11q aberration is sufficient really for diagnosis here. So maybe as more information comes out, they'll change this to a definitive entity. A couple new diagnoses in the high-grade aggressive B-cell lymphoma categories here. One is the lymphomas of immune privileged sites. So this is brand new. There was really no overarching theme in the WHO for this. Here, primary DLBCL of CNS was its own category, and then DLBCL of the vitreous and retina and of the testis are lumped in under DLBCL NOS in the 4R. The WHO5, however, does provide its own little umbrella, placing these lymphomas in these sites under this name. They did this because they share clinical and biologic features with aggressive lymphomas, and they commonly occur in like immunocompetent patients. They're older than 60. All these cases have a similar immunophenotype, that of activated B cells. They can share molecular findings like MYD88 and CD79B mutations, and they generally have a poor prognosis. There is a discussion here that the large B-cell lymphomas of immune privileged sites may someday include breast and skin cases, as they also share some features. ICC does agree that, the potential for putting an umbrella together to lump some of these cases is there. However, they did propose initially a different umbrella name, extranodal lymphoma activated B-cell type. So really along the same vein, they were thinking about including these lymphomas of the immune sanctuary sites, but also including things like intravascular B-cell lymphoma, primary DLBCL adrenal lymphoma, DLBCL of leg type. But ultimately, all these entities, they felt it was too soon to lump them together. It was premature because they are still fairly heterogeneous in terms of the molecular. So they kind of threw that idea away. They have, however, singled out one diagnosis as its own entity, DLBCL of the testis, which is not in the WHO5 and not in the 4R. So a few differences there. An additional difference between the WHO4R and these new types is they do introduce this new entity called fluid overload associated large B-cell lymphoma, at least the WHO5 does. And actually, this is present in other Blue Book series, like in the thoracic tumor series, where it's called primary fusion-like lymphoma, HHV8 unrelated primary fusion-like lymphoma. And ultimately, comparing this to the primary fusion lymphoma, it is very different. Here, cases with fluid overload associated are mostly seen in the elderly. They occur only in body cavities, mostly pleural space, and don't really develop the solid tumors. There's no association with HHV8, but there is, I think ABV is positive in up to 30% of cases. These cases are not associated with immunodeficiency like primary fusion lymphoma is, but they are obviously, as the name denotes, associated with CHF, heart failure, renal failure, cirrhosis, protein-losing enteropathy, those things that cause fluid overload. They seem to be composed of mature B cells in terms of morphology and immunophenotype, whereas the primary fusion lymphoma looks more plasmacytoid. They actually have a very good prognosis. Some of these regress on their own or are cured with drainage, whereas that is obviously not the case for primary fusion lymphoma. And ultimately, the ICC does propose a provisional entity that's very similar to this, if not the same thing. Here they call it HHV8 and EBV negative primary fusion-based lymphoma, even though I think EBV in terms of like the WHO5 category is present. But these have a good prognosis, or have been mostly reported in case reports from Japan and patients with history of like hepatitis C. And then our last case here, this is a 3-year-old girl who was essentially asymptomatic, and mom found a neck mass. It was actually a submandibular mass. She underwent an excisional biopsy. And here you can see on low power that the sections of tissue here have pretty significant architectural effacement. I don't see prominent dermal centers here. And backgrounds of this like fibrotic bands that make it look a little nodular. Multiple cells were seen throughout this case that were atypical and large. So here you can see that there's some background scattered like small lymphocytes and histiocytes, but you have these like multi-lobated cells with prominent nucleoli, multiple nucleoli, the characteristic LP cells, or so-called popcorn cells. You probably know where this is leading. But these cells are positive for CD20, notably absent for CD30. CD3, which highlights T cells, could kind of make rosettes around these big atypical cells. OCT2 was also positive in these, and that's the most reliable marker in this case. And then BCL6 was also positive here in these atypical cells. So this was called nodular lymphocyte predominant, or NLP, Hodgkin lymphoma in the 4R. The 5 keeps the same naming system, but the ICC has officially moved this out of Hodgkin lymphomas and put it in the B-cell lymphoma category. So, and the reasoning for this is the neoplastic cells in nodular lymphocyte predominant really show that functional like B-cell programming, whereas those in like classic Hodgkin do not. And it's actually much closer to like T-cell histiocyte-rich large B-cell lymphoma. But the WHO5, they agree that, you know, it is closer to that other entity and not so much Hodgkin, but they decided to retain the name to not interfere with ongoing clinical trials. Whereas the ICC decided to remove it altogether because they felt that the biological differences, the clinical implications were pretty different. The ICC does recommend, though, to keep using the architectural patterns, the fan patterns. I think the person who wrote this up was Dr. Fan. But here they kind of rearranged the different variants into different grades. So the classic patterns are called grade 1, and the variant patterns are called grade 2. So what are these patterns? We'll go through them very quickly. Basically, the patterns that have more of a nodular architecture that's preserved are called the classic patterns. Those that have a loss of this nodular pattern, increased infiltration by T cells, and have a more aggressive clinical course, so patterns D through F, are called variant patterns, and this is especially with grade 2, which should be treated more similar to DLBCL because it's a more prominent aggressive clinical course. And finally, our very last diagnosis to talk about here is mediastinal gray zone lymphoma. If you notice kind of throughout the talk, things that had a star were like new entities. this is highlighted in red because this is actually not really a new entity. It just changed its name. So before it had been called mediastinal gray cell lymphoma, but it wasn't until the WHO4R that this had been named B-cell lymphoma, unclassifiable with features intermediate with DLBCL and classical Hodgkin lymphoma, more so like the nodular sclerosis type. But this obviously shares features with both, and specifically primary mediastinal B-cell lymphoma. Both new classification systems agree that with the molecular studies that show that it's on a continuum with these two entities, it's not a mimic, it is on the spectrum. These cases should only be named so if the lymphoma is in the mediastinum. It's pretty characteristic that these are in young men and have pretty poor survival, so they compared to those other cases. So they want to make sure that cases only mediastinum are called as such. Cases that have similar morphology or IHC pattern, but are not in the mediastinum, they both classification systems say that they should be called DLBCL, especially as they have the same kind of genomic profile. All right, so I know that was a lot. Just some final thoughts though. I think most of us can agree that while changes are appreciated and merited, there really needs to be a unified system. This is the first time in 20 years where we don't have a system, and now we've returned to a dichotomy, and that just seems to leave the door open for problems. So I think really there needs to be a unified system so that there's common language for all practitioners everywhere across the globe, so that clinical trials are easier to, keep track of results, and obviously ease for patient care, but also ease for pathologists. Like, it seems like it could be a pain to have to report all this out. But in the meantime, it seems like that is our option, to report both diagnoses for both classifications. So these are my references. And then just a quick note of acknowledgements. I want to give so many thanks to so many people. First of the list is Dr. Linden. Dr. Linden kind of took me under his wing and brought me into like CAP committees, and really helped me develop my love for heme. So thank you so much, and has been so helpful in all my projects related to heme. And that really goes for all of the people in HemePath, all the staff, all the faculty, Sue and Chris. You guys make HemePath just very, very enjoyable, and just make it great to be a resident here. So, and additionally, that goes for all of the staff, the faculty, PAs, cytotechs, everybody in the AP and CP departments. And then lastly, I just want to thank all of my co-trainees, the fellows, and the residents for just being so fun to work with, and helping kind of facilitate my love for pathology. So, all right. So hopefully I left some time for questions. I know that was a lot of information, but please feel free to ask questions. And I'll stop sharing.
Hey, Elena, this is Amy Beckman. Thank you for that talk. I have to admit, I'm so glad it's recorded, because I'm going to need to go back and watch that maybe 2 or 3 times to get all the information. So I'm sure I speak for everybody on HemePath that we appreciate your efforts to try to summarize this very complex schema, new schemas that we have. I'm wondering if in your reading, we haven't wholeheartedly adopted these and started reporting them when we're making our diagnoses in HemePath yet. We're kind of starting to, but in your reading, did you get a feel for whether pathologists at academic centers or in communities are really starting to switch over to these new classification systems? And then maybe a related question is whether clinical trials and, of course, our hematologist, oncologist colleagues are really starting to put these into use.
Yeah, I can't give like a great definitive answer on that, but overall, like the papers I was coming across, it seems like, as we transition over, people are really reporting out everything. And because of that, I don't think clinical trials are really seeing these new names yet. They're still kind of keeping track of those old names to keep track of how the treatments are going. So I guess we'll see. Hopefully we'll get more information as things transition over. But I think really everyone's being pretty careful and making sure everyone's on the same page in terms of, what classification system is being used and what to actually call this in the meantime. I think LLP Hodgkin is like a great example of that, where, everyone agrees what it should be, but they're hesitant to do anything because they don't want it to impact patient care.
Thanks.
Yeah.
Elena, this is Dr. Dayton. I just want to also emphasize what a fantastic presentation you just made. Extremely helpful. I have been carefully parsing through all of the, both the online edition with the ICC publications to prepare for presentations in Vietnam, and I will probably steal from you a little bit. But more importantly, something that I keep noticing keeps repeating itself in the online WHO 5th edition is that this acknowledgement, this understanding that that this is the World Health Organization, and there are resource limited communities and countries that can't do these things. And so the minimal expected requirements for diagnosis, for making diagnoses, are actually pretty minimal. Okay. And they seem to keep emphasizing that more specific testing, including molecular testing, is for research purposes. So where do you think we should be at? I mean, I know how I'm going to advise Vietnam is that they all need to think about getting flow cytometric immunophenotyping standardized in that country, okay, which could be 10, 20 years off, but they need to expand their immunohistochemistry and improve their basic histology. But we're the University of Minnesota Medical Center. Are you advising that on every single heme path diagnostic case, we put two different diagnoses, WHO 5th edition in parentheses after that diagnosis, and ICC in parentheses after the alternative wording?
Oh, that's a great question. Yeah, I think obviously if the molecular is very different and denotes, a stark difference in treatment and like patient outcome, I think it'd probably be a good idea to like list both, especially as we're trying to keep track of this name with clinical trials. But I think in cases where, if you're thinking about follicular grade or lymphoma, follicular lymphoma 1, 2, and 3A, where it doesn't really impact the patient care that much, I think, as an academic institution, we probably should try to report as much as possible, but then we also have to like be careful of like overusing resources too. So that's an interesting question. I don't have a great answer for you. I don't think in every single case we have to do that, but probably more so than, community hospitals and places that have limitations to their assays that they can perform. I appreciate you bringing that point up because I think it's interesting how, the WHO-5, the whole reason for the two new classifications, or a big reason, is because of the improvements in molecular and the findings associated with molecular. But I appreciate that the WHO-5 acknowledges that that's not reasonable for everybody, and that, you won't be doing this halfway across the world in a small, tiny area that's just trying to, get by. So I think I really like that they pointed that out. To me, it just seems more practical.
Okay, and Betsy had a question.
Yeah. So again, it was a terrific talk, and I will be watching it many more times than Amy Beckman in order to get myself more up to speed. But one of the things that strikes me is that really the diagnosis depends on integration of the immunophenotype and the morphology and the genetics in some of these cases. And so how do we achieve that in our current situation where there's different time points for different things coming out? I mean, some of them are just limitations. For example, in a CLL case, we need to do that FISH on certain stimulated cultures that take 3 days in cultures. We have no options about that, as opposed to, for example, a Burkitt or something like that, that you can do right away. But I guess the question is, do you think that until there's some way of integrating a single report, because right now flow comes out, then morphology, then cyto, or sometimes flow cyto, however it is, it varies from case to case. Should once all of those results are in, would you recommend that those results be relooked at by somebody in hematopathology or other who's skilled at doing that, and be able to make sure that everything reconciles and you can come to a final diagnosis?
Yeah, that's hard when there's so many components that are kind of pending. Yeah, I think that would probably be best served for our heme paths to answer that definitively. But I think in terms of, just good communication with our clinicians, letting them know that this is what we're thinking and that this is kind of, a preliminary but probable diagnosis, that we will probably still assess all the different parts that are coming together. I think in some cases, especially those that have more emphasis on like the cytogenetics that are coming in, it's probably still a good idea to review everything that's coming together and make sure it has a unified diagnosis, especially as we're kind of branching out and we want to be as careful as possible. So that's just my personal opinion. But thank you. Yeah, it's hard. Heme always has so many components to it, so it's hard to keep track of everything that's coming in for a unified single line diagnosis.
So just to answer that, we do try to do that, Betsy. We generally keep a stack of cases that we know need some sort of follow-up to integrate. And sometimes those results are coming back to us as results like the heme docs would get to, which can kind of help trigger going back to a case. But it does require a lot of effort on our part to track things and and follow up on that. So it's not the most ideal system. And most of us have some sort of list or pile of slides or something where we're waiting for follow-up studies to create an addendum and integrate the data.
Okay, that's it for today. Good job, Elena. Congratulations. You are now finished with grand rounds.
Bye, everyone. Thank you.